important things to look at. Neurotransmitters in the gut, motility issues, and the rest. So it's actually multifactorial in origin, as we know from today, and we have many players in this causing this, and we know that the main players are the gut and the brain. So, and it's a bidirectional association, that there are abnormalities in the brain which can trigger and exacerbate the symptoms in the gut, and the gut symptoms then can exacerbate abnormalities in the brain, like anxiety, depression, and the rest. So the characteristic feature of IBS is, one, the patient usually have recurrent abdominal pain, and this pain is associated with changes in stool form or frequency. So why should we discuss IBS? It actually affects more than 1 billion people in the world, and it's rising in Kenya from a study done in Kenya. And actually, you'll see, if you are doing clinics or if you are doing outpatient service or nurses who see patients, you'll see that there's a high clinical burden. You see these patients, we call them circuit patients. They'll come to you tomorrow, they'll go to someone else, another time they'll come back, they'll go to a different hospital, they'll visit another, they'll even travel out of the country to seek help. So it's important to recognize this, because it's a burden to us, and high economic burden, both direct and indirect costs. So these are the common symptoms of IBS. Of course, abdominal pain is key. So abdominal pain, all patients should have abdominal pain, and they may have altered bowel habits, either constipation or diarrhea, or just a change in stool form. And sometimes they have mucorrhea, some mucus in stool, and there are other symptoms. Bloating is a common symptom as well. So as we said, we really don't know why patients get IBS. But with time, we understand that 60% of patients usually have an infection, actually food poisoning. We believe that post-infectious IBS probably is the majority of our patients in these parts of the world, because of the situations we live. So once they get, let's say, an infection, a Campylobacter infection or E. coli or food poisoning, there's some autoimmunity that develops with small intestinal bacterial overgrowth, which now causes gas production, motility issues in the gut, and then they develop IBS. So if you have, let's say in this room, we eat from lunchtime, we get maybe Allah forbid, an infection, let's say a food poisoning from the food. 11% of us will develop IBS. So that's quite common. Eh? So from this, we see that the interactions from the brain, from the gut. From the gut, we have the immune system, the microbiome, we have the smooth muscles, we have some genetic influences. So this is the interactions we have. So you might get this food poisoning, then we have interactions with the receptors, and this causes some pathways to the brain where they sensitize the nervous system, where these patients now, the visceral stimuli, they are sensitized and they are hypersensitive. So we believe that it's a bidirectional communication and the interaction. And this, understanding this helps in treatment, as we talked about. Probably we are not there like in lung cancer where you have EGFR mutation positive, then you do this and this, but you are coming there to IBS as well. So what causes the pain of IBS? One is visceral hypersensitivity. How do you tell patients? This visceral hypersensitivity just means patients usually have a stimuli. Most of us get a stimuli if you eat something like beans, if you add any food. Like non-digestible carbohydrates. So usually there's some gas, but this gas for most patients, for most people, doesn't cause anything. But for patients with IBS, they usually perceive it as pain, yeah? So if you understand some patients with visceral hypersensitivity, you understand that these are patients who can be given some neuromodulators, peppermint, as treatment options. Some patients will have, let's say, altered gut motility. Patients, of course, we know that gas, some carbohydrates cause some increased motility in the intestine, like FODMAP diets, so you can give antispasmodics. Some patients have very high levels of stress, anxiety, and in these patients, either related to their GI symptoms, you know that brain therapies like CBT and hypnotherapy will be of help. And as we said, that there's microbiome imbalance after probably an infection. And this imbalance, either small intestinal bowel overgrowth or otherwise, may respond to antibacterial therapy like rifaximin, probiotics, and dietary changes. And of course, there's new research on serotonin, increased serotonin, reduction in serotonin depending on the symptoms, and there's role of these anti-serotonin therapies. And now we know that it's not just functional disorder. What we say is not just a mind problem. We have low-grade inflammation in some patients, especially in post-infectious IBS, and there's role for anti-inflammatories. So the same for bloating. Usually bloating is caused by visceral hypersensitivity. Some food stuff like FODMAP diets cause a lot of gas production, motility, like in constipation, they have slow transit. You may need to give some prokinetic agents. If you have bacterial overgrowth, then there's a role for rifaximin and probiotics. And some patients, they just have abdominal wall dysfunction, and maybe breathing exercises and physical therapy may help. Okay, so for many years, the Rome Foundation was the authority in what we call functional disorders, and now currently termed as disorders of gut-brain interactions. So since 30 years back, they've developed these Rome criteria from 1 now to 4. The latest was Rome 4. So the latest Rome, which is 4, it wanted to shift clinicians from using the term functional, which creates stigma, to this new term that it means there's some problem with the interaction between the gut and the brain. And the Rome 4 is also came to reduce excessive testing in these patients. Previously, these patients, you know, they'll have all the tests in the world until the doctor will tell them, okay, this probably it's IBD, probably this is cancer of the intestines, probably this is this and this, and they'll have multiple tests, including PET scans or excessive testing. And then at last they say, okay, now because we didn't find anything, this is IBS. But that's wrong. Currently, from the first visit when the patient comes, if you don't find any danger signs, then you need to create a positive diagnosis. You say you have irritable bowel syndrome, and it's not a diagnosis of exclusion. And now we go into mechanistic informed treatment, where you look at the underlying, because we said it's multifactorial, multiple mechanisms. You look at the underlying mechanisms and you target that for treatment. And we know that these patients, they need multidimensional care. So the current criteria for IBS, you need to have abdominal pain, at least one once per day for once per week for at least 3 months. And either of these, the pain is associated with defecation, the pain is associated with change in frequency, maybe they're going maybe 5-10 times in a week, maybe that's not normal for them, maybe the stool form is usually maybe diarrhea or constipation. So they can either have of this, then you make a diagnosis. So usually use this Bristol stool form scale in the clinic. You can print this and ask the patient how many times they get this type, like the diarrhea, the separate hard lumps, this constipation type, and how many times they get the watery type. So if they get more than 25% of this, then they have IBD diarrhea, IBD constipation, sorry, and if they have mostly watery form, then they have IBD diarrhea, and in between they have a mixed, these phenotypes, it's useful, but it's not like the end. Once you have IBD diarrhea, there are other mechanisms you need to look. So which patient should you send for colonoscopy? So patient with diarrhea, you need to do a fecal calprotectin. If it's elevated, then you know this may be IBD, they need to go for colonoscopy. Patients who are elderly, above 45 years, ideally they should have a colonoscopy for screening, so they should be sent for screening. If there's history of bleeding, maybe suggestive of IBD, any danger signs, and any patients with, let's say, coexisting autoimmune disease or suspected microscopic colitis should be sent for. We rarely use this, but because it wasn't available, but currently we have available. So patients should be sent for hydrogen breath tests. As we said, there is increase. Many patients, almost 10 to 30% of IBS will have SIBO, what we call small intestinal bowel overgrowth. So these are patients when you do the hydrogen test, you can pick them up and probably they may benefit from rifaximin or probiotic. And some patient may have lactose intolerance, so this patient, if you send them for a lactose intolerance test from the breath test, they'll actually, you get a diagnosis and help them. Okay, so there are mimics. Of course, in these parts of the world, infection is common, so you need to rule out infections, do a stool analysis. TB, IBD is rising. If you have weight loss, blood in stool, then you need to investigate. Any red flags is not IBS, or you may have IBS with another diagnosis. So any patient with a red flag should be evaluated for that. We talked about this. Thyroid is quite common also. Patients with either chronic diarrhea should have a thyroid to check for hyperthyroidism. If they are probably constipated, check for hypothyroidism. Patients with an overlap with functional dyspepsia should get a H. pylori test. And most patients with IBS don't have epigastric pain. So if they have this, you need to think about functional dyspepsia, peptic ulcer disease, and do the necessary test. Okay, so overlap between these, what we call the disorders of gut-brain interaction is quite common. Most patients, they are treated here. Most patients with IBS, I see them, they are treated here. They always get H. pylori test. Like they'll have 10 tests of H. pylori. So because functional dyspepsia, so patient may have functional dyspepsia and IBS. So you need to pick these patients. So blotting of functional dyspepsia usually above the navel usually occurs less than an hour after meals. If the blotting occurs quite later, probably it's not related to functional dyspepsia. So let's talk about two cases just briefly as I wind up. Patients with IBS so that you can see how to manage them. So Mariam, a 26-year-old female, comes with, you make a diagnosis of IBS diarrhea. So you need to get the predominant symptoms. So she has diarrhea, she has urgency, she has bloating. She doesn't complain of, she has pain, but is not her main problem. No danger signs, but she also anxious. You know, she doesn't want to go out. She's, because of urgency, she has to make sure there's a washroom anywhere she goes. So she has quite some central symptoms as well. So basic labs are normal, CRP normal. So how do you handle such patients? So as we see here, this patient is on the diarrhea side of the IBS. So if they have diarrhea, then the first line treatment is probably antidiarrheal like loperamide with much evidence. And most of these patients should be treated with rifaximin, especially if you don't have a hydrogen breath test. So this for the diarrhea. If you can test for bile acid malabsorption test, then you can probably, if they're not improving, give this, or you can try Odan-Centrum, which is available. Probiotics, there's controversy, most of us use, so you can also use in patients with IBS diarrhea. If they have pain, which she didn't have, you will go through this pathway. So we need to target her symptoms. She has diarrhea, so we treat. She has bloating, so bloating, probably rifaximin is good with bloating, so we gave her rifaximin. And also she has some anxiety, and we'll talk about that. She also, so we need to look at her, what are the mechanisms of her symptoms. We know that she has altered microbiome because she has diarrhea. It's a rapid transit pathology because of the diarrhea. You need to take care of that. That's why we give loperamide. She may have bile acid malabsorption. You need to think about that. She, because of the predominant bloating, she must probably has increased gas production with dietary, like increased FODMAP diet. She has brain gut dysregulation because she's quite anxious. She's avoiding going out. So then we develop a multi-dimensional care approach to this. So probably her prescription will be like this. She will give rifaximin for 2 weeks, 3 times a day to target the bloating. We'll give some loperamide for the diarrhea initially. You'll encourage a low FODMAP diet. Usually it needs to be done by a dietitian as per the guidelines, but you can do a short FODMAP instruction in the clinic. Because of our anxiety, you need to do some CBT, cognitive behavioral therapy. You need to encourage a good lifestyle, regular meals, avoid dairy triggers, walking. Of course, these are tests you can send for hydrogen breath test, total calprotectin, bile acid screen, and then you review in 6 weeks if there's any improvement. So the other patient, just 3 slides more. These are the other side of the spectrum. This is a lady who comes with constipation. So you make a diagnosis. She has stools constipation, but she complains of abdominal pain, severe abdominal pain. She usually links the pain with when she's quite stressed at work and at home, and she has not responded to laxatives. So the other basic tests are normal. So this is a patient now. You look at which symptoms are prominent, this abdominal pain and constipation. Look at the mechanisms. She has visceral hypersensitivity. Why is it important here? Because this sensitivity may be treated with neuromodulators to relieve the pain. She has a slow transit. That's why she has constipation. Probably needs to be taken care of. And also she has a lot of anxiety and causing her symptoms. So then you develop a multi-dimensional care plan. So as you can see here, she's on this spectrum. You need to start with probably laxatives like PEG, polyethylene glycol, which is the recommended one in the guidelines. If she's not getting improvement like in her, you need to go into these secretagogues like prucalopride, linaclotide. She has very severe pain, so you can give antispasmodic as first line, and then probably you should consider neuromodulators. So because she has constipation, the first line neuromodulator is an SNRI or SSRI, and tricyclists may be used, but not the first line here. Okay, so this is her prescription. So you need to start on secretagogue because she was not responding to laxatives. So prucalopride, give some PEG, probably sachets. For the pain, you can give peppermint oil, you can give hyoscine, mebeverine, cyclomen, or tillinium, but need to monitor for worsening constipation in these patients. You need to send to a dietitian to start on a plan, probably start on a soluble fibrous psyllium, fibrogel we have in the country. You need to reduce constipating foods. Because she has quite stress with her symptoms, probably she may need some hypnotherapy or gut-directed CBT. Lifestyle modification, increase water, regular meals, walking. She may have dysnergic defecation. So if they are not getting better, you might refer for an rectal manometry. So by 6 weeks, if she is still in pain, then you may consider neuromodulators. So beyond ROM, what's coming beyond ROM? Next year we'll have ROM 6. So probably it will be more mechanistic informed. So you target the mechanism involved. It will be more of multidimensional care, as we said. We'll remove probably the subtyping into static like IBS-C, IBS-D, just static categories, and probably go into mechanisms, pathophysiological classification. We'll see more of overlap, how to manage overlap syndromes like functional dyspepsia, and we'll see incorporation of these biomarkers like calprotectin, hydrogen breath test, bile salts test. So if you can't do FODMAP, probably what to do? This, you can do a traditional dietary advice, just what we say to patients normally in the clinic, and also you can try a Mediterranean diet. And in conclusion, I know it's a big topic and probably there may be questions, but ROM4 enables a positive symptom-based diagnosis. From now on, don't tell patient that we have to exclude other things for you to say the patient has an IBS. So you need to make a positive diagnosis. If the patient has no danger signs from the onset, then you say you have irritable bowel syndrome from the onset, okay? And then we need to test smart. We need to use tests to guide treatment. Let's say if the patient has a diarrhea or some bloating, you need to do a hydrogen breath test. If they have diarrhea, maybe post-cholecystectomy, you need to do bile salt analysis. If the patient needs colonoscopy, as we said, you need to tailor based on the red flags, and not just all patients should undergo like a full battery of tests. And we need to support a mechanism-informed care rather than blanket testing for these patients. And we need to treat strong depending on the symptom, depending on the mechanism involved, and beyond ROM that we got into precision care, as we said in lung cancer as well. Thank you.
Thank you, Dr. Mansour, for tackling that normally very tricky topic. So what I've seen in the group is that people are just taking photos of the prescription. The rest of the IBS and all that we will refer. So now that I've seen some pediatrics walk into the room, I think it would be a good time to deal with the pediatric topic before they get tired and leave. So our next speaker will be Dr. Swale Shabal, a consultant pediatric surgeon. Keep it as light as possible for the kids.
They call me a childish surgeon, that's why they came to listen. Thank you very much. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Dr. Marlon. The other things that are not mentioned, Shukran Al-Ihsan for coming. I invited them because kammp never invites them. So I invited them. I think our beliefs should be non-partisan to kammp. Al-Ihsan has its audience, the other channels have their audience, therefore everyone has to be invited for us to spread the word. So Al-Ihsan is my people. So my name is Dr. Swale Shabal. I'm a pediatric surgeon. I'm a fellow of the American College of Surgeons, and soon I'm getting a fellowship in from the College of East Central and South African Surgeons. Dr. Amina Nyangoso appears there because she helped me collect data. She will be my first resident in pediatric surgery at Coast General Hospital. So how are we bridging the gap? So there are significant challenges in Kenya and across Africa, both in adults and the pediatric population, in accessing the surgical care. The gaps in pediatric surgery include lack of enough specialists, infrastructure, specialized equipment. And there are many papers that have looked at this, So the disability adjusted life years is used to estimate the burden of disease. So there was a paper that was written in 2015 that was comparing Kenya with Canada, although I don't think those two should be compared. So for simple cases like okidopexy, our disability adjusted life years were 72 months. 72 months is approximately 5 years. 5 years is 60, so 6 years. So you can imagine if a simple procedure like okidopexy takes a child 6 years to get the procedure done, what does that mean? And if undescended testis is associated with infertility, what does that mean? So the best time to do okidopexy is before 18 months. That's when primary spermatogenesis starts. So if you're doing them at 6 years, you can imagine the number of infertile boys we have in Kenya. For cases like anorexoplasty, the disability adjusted life years was 74 months. So that's the burden we have. So then other papers looked at the critical shortage in capacity to deliver safe pediatric surgery. Remember, pediatrics are not small adults. You cannot use adult things on pediatrics. I'm talking about mainly safe anesthesia. Okay? There are machines that can ventilate a baby. There are machines that cannot ventilate a baby. For those machines that cannot ventilate a baby, therefore you cannot let the ventilator continue. You have to do it manually. When you're doing it manually, how do you know the tidal volume that you're giving? Yeah, you can easily cause things like pneumothorax when you're bagging yourself. So where are we in Kenya? How are we trying to bridge this gap? Alhamdulillah, before the University of Nairobi started training, and for those at my age and above, they know how toxic pediatric surgery was. Yeah, we were among the first pygmies that were used to make new pediatric surgeons. So before 2014, that's when the University of Nairobi started the program. There were around 10 pediatric surgeons in the whole of Kenya. Right now, we are 45, but still, you can see the concentration. 33 in Nairobi, and the rest are in the other counties. Alhamdulillah, in Mombasa, we are now 3. Okay, we are now 4, including Dr. Mwea. 2 in Kilifi, 3 in Kiambu, 1 in Nakuru, 2 in Kisii, 1 in Kajiado, and 1 in Kisumu. The number of pediatric anesthesiologists is still low. There are 13 in Kenya. But also the University of Nairobi around 2015 started a program where they were doing a fellowship in, they started a fellowship in pediatric anesthesia. And they have trained many in Africa. They usually make sure they take a student from outside Kenya. So we have 2 in Mombasa, Dr. Kochi and Karen in Aga Khan, 1 in Kisumu and 2 in Uasin. So the training centers for University of Nairobi, the training centers for pediatric surgery in Kenya are University of Nairobi, Moi University, but the Moi University is not a university program, it's a COSEXA program. And Kijabe Mission Hospital is also a COSEXA program, and I'm happy to say that Coast General has been accredited by COSEXA to start a training in a fellowship in pediatric surgery. And as I said, Dr. Amina will be our first student. She's already done 1 year technically, so 2 more years we'll have a pediatric surgeon from Coast General. So the journey of pediatric surgery in the coast, how did it start? I remember when I was an intern in 2004, Dr. Kambuni used to come for camps but the camp was one day, on a Friday, the last Friday of every month. Him and Professor Qureshi, they came, one did the pediatrics and the other one did neuro. So after that, COVID came, but COVID came with a blessing. Dr. Swale was frustrated in Nairobi and decided to move to the Mombasa County. So after we've come, this is my first case. I actually saw Hussein last week in the clinic. He was my first case, a case of anorectal malformation. Came as a neonate, we did all the works, and he's now very continent and very happy. So I'd like to talk about a few cases. Circumcision, as we know, is a simple procedure, but can go wrong. So this is one that we corrected. Then if I remember Dr. Rukia's presentation yesterday, remember she talked about, we are lucky as surgeons, we go in, we see organs, but everything should be reminding us about Allah. Now you can imagine me or Amina who sees the abnormal things. And then you see the effect of the abnormal things. Then you see the effect of this child being brought late. They should all be taking me to God. And that's why that presentation touched me very much. Because sometimes they used to keep me on a Friday list. And sometimes 3 Fridays would pass. And I'd be justifying it by saying, okay, some people will tell you because of Friday tatu, lazima usilimu tena, sijui, such things, right? I would justify I'm giving such kids a service. So it's justifiable. I know it's not, but so it should remind me about God. My work, as much as I'm giving back and I'm getting thawab for it, it should remind me about God. And therefore, pediatric surgery reminds us about God more. So these are a few cases that we do. And I can tell you, not all our diseases in the coast are this simple. This is something simple. This would something that we would sort and this baby will be okay. But there was a time that, I don't know, it's residents in Rolikwana Kazingumu, but there was a time we used to get those things that are called Christmas trees, where you open and you can't do anything, you just close and just tell the mother to wait for mtoto arudi kwa mola wake. So, alhamdulillah, now these things can be sorted here. Previously, they had to be transported to Nairobi, and if you are a Coast General patient, then it will mean an ambulance to Nairobi. This is a case we did recently. So remember, on pharmacists, pediatric surgeons will tell you we can't do them when they're born. We'll have to dress until it granulates and form a ventral hernia. So this is a 2-year-old who came with this ventral hernia. You can see how ugly it is. Most of the contents in an omphalocele is the liver. So here we've mobilized the liver. And alhamdulillah, we managed to do component separation and primarily closed the abdomen. And this is our outcome. Recently also, we got a child with an abdominal mass, but then also had a scrotal mass. Then we said the abdominal mass was cystic, so most likely it's connected to the scrotum. This is the mass after we excised it, and alhamdulillah, the result came as a benign seminoma. So it was actually the testis that was, it had spread to the abdomen. Cases of hypospadias are now sorted locally. This was a rare case. Do you remember this bicycle? Yeah? You remember? No. You know, nowadays we have second-hand bicycles from the UK, from Europe. Everyone is riding a good bicycle. But when we were growing up, we used to have bicycles with no pedals, right? So, and we used to take our bikes to fundis. Do those fundis still exist? Yule majengo bado iko pale King'orani. Yeah, so a child was playing with a puddle of water. Then an older child was riding such a bicycle with no pedal. It was just ile chuma. Of course, if a bicycle does not have a pedal, most likely also the brakes don't work. So he was fast. And when he saw the child who was squashing in front, he panicked and turned. The bike skid, and the pedal hits the younger child's perineum. For 2 years, this child was managed by a general surgeon. Alhamdulillah, he managed the wound and the wound closed. But and had been taken to theater like 4 times for debridement, the wound healed. But the child remained incontinent. He couldn't control stool. So the mother for 2 years stopped the child from going to school, because you cannot go to school smelling of feces. When they came to us, we did an MRI, and it showed clearly the sphincter had been injured, and the levator ani was also injured. We did an EUA, we confirmed this, and we took the mother to theater so that we confirmed the findings, because you can imagine you're dealing with the 6-year-old, then you're telling the mother you want to do a colostomy. So first we diverted stool, repaired the sphincter later, and eventually, alhamdulillah, we managed to close the colostomy, and the child is now continent and is back to school. Children, intussusception occurs in children who are around 9 months to 12 months, right? Most of us know that. This child was 13 years, presented with what, in Aga Khan, they'll do a CT scan, right? So when they did the CT scan, the report was intussusception. I was like, most likely not, unless this child has a tumor, it has caused intussusception or something. But most likely with this age, and he's a boy and he's 13, most likely it's appendicitis that has caused the intussusception. And we did, is there a pointer? So you can see this here is the appendix. You can see this here is the intussusception. That's the cecum there. You can see it's edematous, and that is the appendix. So it was appendicitis causing intussusception. So from the time we came to Mombasa in the first year, it was September 2020. So September 2020 to 2021, we did around 600 cases. In 2022, 429, 2023, 338, and currently in 2025, we've already done 456 cases. So I hope we're bridging the gap. So what are our collaborations? Of course, I'm a member of Kenya Association of Pediatric Surgeons. Kenya Association of Pediatric Surgeons is involved in the training of pediatric surgeons. We started receiving pediatric surgeon students from other countries. We've trained a student from, where is Nani coming from? From Lesotho. We also collaborating with Surgical Society of Kenya. They usually have annual camps, and CAPS usually gets someone involved to go sort the pediatric surgeons. And I can say proudly that we had a camp recently in Kisumu, no, in Homa Bay. In Homa Bay, and Amina asked me for permission that she wants to go join the SSK. When she got there, there was no pediatric surgeon, and all the pediatric cases, including a component separation, was done by Dr. Amina. Kids OR, we have managed to secure a $300,000 fund. Kids OR is going to build for us a pediatric surgery theater only in Coast General. So, as I said, we have been accredited to become a training center, and that's in collaboration with COSEXA. We also have, mashallah, Mombasa has produced people who are working all over the world. So everyone knows Dr. Sabarwal, the ENT. He has a son who's a pediatric surgeon, and he is the head of department in Great Ormond Street. So we collaborate with him when it comes to things to do with urology. He's more specialized into pediatric urology. University of Nairobi, we usually, because generally is external rotation for the University of Nairobi pediatric surgical students. And with Pan-African Pediatric Surgical Association, we are currently one of the institutions who are, we're trying to create a trauma registry for Africa. And we are in the starting, we're trying to develop a tool that will be in files for all pediatric trauma cases. Professor Bindi is also originally from Mombasa. She is the head of department pediatric surgery at the University of Texas. She does annual camps at Coast General every year, and it is usually sponsored by Rotary Club of Mombasa. Again, I wouldn't mention names, but there are a group of philanthropists that we have brought together, and inshallah soon, or in a couple of years, if anyone has been to Moi University, there is a building called SHU for Africa, where the pediatric population is served from that building. It has everything, including a pediatric ICU, a pediatric theater, and the pediatricians are also homed there. So soon we'll have one coming up in Coast General. So as CAPS, also Coast General was, after I came, I pushed people. Coast General was the first place Kenya Association of Pediatric Surgeons did a camp. We did it for 2 years, in 2021 and in 2022. The first year, the numbers are low because we did it for a few days, because it was our first Kenya Association of Pediatric Surgeons conference that we brought to Mombasa. So after that, we agreed that we can have the camp everywhere else, but the conference has to be in Mombasa. So Nakuru 2023, we did 150 cases. In Garissa 2024, we did 101 cases. And this year we went to Kisumu, we did 123 cases. So this is how, in a small way, we are trying to bridge the gap for the pediatric population. I've talked about this, and with the University of Nairobi and KNH, we still have, just like it was emphasized, MDTs are important. Now that I'm a consultant, it doesn't mean I can sort out everything. Some things I need help. And MDTs are very helpful. We do them on Zoom. So that's our collaboration. And this is the kind of theater that is coming to Coast General for the pediatric population. Kids OR have done this. And it will also be fully solar. The energy that we're going to will not depend on KPLC. The batteries are already in Coast General, the solar panels are already in Coast General. So where are we going? We're going to have a special pediatric surgery theater in Coast General soon. We're starting a pediatric surgery fellowship in Coast General, and like I said, we want to create the Center of Excellence for Pediatric Surgical Care. Thank you very much. And before I go, remember, risk, everyone ishaandikiwa sio? That do you agree? So following Dr. Abu's emotional talk yesterday, I just want to remind us that, you see, Dr. Amina is going to be competition, right? After I finish training her. But si riski yake ishaandikiwa, na yangu si ishaandikwa. So why would I block her from getting into Pandya because atakuwa competition? My risk will not change, it will not increase. Therefore, what I'm saying is, let's stop looking at people as threats. Kila ya mtu yake ishaandikwa, just do your work, do your bit. It will not increase because you're the only one. Thank you very much.
Shukran, Daktari, and thank you for the great work you're doing for the kids in Mombasa. And the partnerships, I think, it's a good sign. Sometimes we as clinicians and our associations and the people we know in and outside the country, we can help improve our public sector. I'm sure CPGH in the county might never build such a theater for pediatrics. But because, Daktari, the people you know and the people you are affiliated with, you can use your influence for us to improve, especially in the public sector. The private, I think, one or another, the market forces will sort it. So thank you so much. And I think going forward, all our senior consultants, you should be coming with your students, so that you introduce them to this and we know them as well. Thank you so much. I think then our last, our last talk is already on the screen by Dr. Faraj. Let me introduce him properly. So Dr. Faraj Al-Kazim, orthopedic surgeon and spine surgeon and medical physiologist, based in Nairobi, and also a visiting consultant at St. Mary's Hospital. Holds an MD and MSc from University of Nairobi, has a fellowship trained in spine surgery, and has also undergone specialized training in robotic joint replacement surgery, among other advanced orthopedic techniques. His clinical practice spans spine, trauma, arthroscopy, and arthroplasty surgery. Dr. Al-Kazim is currently pursuing a PhD at JKUAT, where he also serves as a senior lecturer. Beyond his clinical and academic roles, he is the programs manager for medical outreaches at Centers for Health and Education Program. That's a local NGO dedicated to improving access to specialized healthcare in underserved communities. He'll be presenting on robotic joint replacement surgery. Karibu Daktari.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. It's truly an honor to be here and very exciting opportunity to share information on one of the latest advancements in orthopedic surgery, which is joint replacement surgery. Now, joint replacement surgery is offered as a management strategy for osteoarthritis. And as we all know, osteoarthritis is the degenerative disease of joints that leads to painful, stiff, reduced range of motion, disability, feeling of instability, as well as multiple other symptomatology that come about with osteoarthritis. It is said that we have about 600 million people living with osteoarthritis at any given time all over the world, of which 2/3 are as a result of knee osteoarthritis. So knee is more common than the others. The remaining 1/3 is the remaining other joints. Now, we don't have a joint registry in Kenya. However, it is said that, according to AMREF, we have about 9 million people suffering from osteoarthritis at any given time. So this is a great public health concern. Loss of function, disability, increased need for caregivers, as well as the cost of managing osteoarthritis. Now, the management of osteoarthritis ranges from very basic physiotherapy all the way to surgery. And surgery can range from arthroscopy, reconstructive surgeries, as well as joint replacement, which is much more common. Arthroplasty or joint replacement is a cost-effective strategy in management of osteoarthritis because it restores function, it controls pain, and keeps the patient happy. And there is an increased numbers of joint replacement surgeries that are being done. Now, what do we do during joint replacements? We basically meticulously remove the distal femur, proximal tibia. I recognize that this is a very mixed audience, and put a prosthetic femur, prosthetic tibia, and a polyethylene in between, and basically have replaced the worn out joint. So this is the final product. Kind of looks like this, the photo I took recently from one of my patients, and on X-ray, it looks like that, basically, compared to the disability. So this is a patient who came recently. This was 3 months post-op. She was boasting with her knee. It's now pain-free. She's happy. I tried to hide her face. I didn't manage to hide the smile. But it shows you how quite happy she was. And she came with a walking aid and basically in a lot of pain. And she came, she was boasting, and I knew I was coming here. I took a video. But it hasn't always been this rosy. Joint replacement surgeries has progressed over generations of, it's changing itself, over generations of strategies from very primitive care to much more advanced care over the years. Now this is how it all started. Just very briefly, then we go into robotics. I'm not sure why the slides are changing. You have a timer on? It's automated. Okay, so this is how it all started. Back in 19th century, they used to do excisional arthroplasty. So they remove the distal femur and the proximal tibia and basically leave you like that. So what are they doing? They're dealing with the pain, they're dealing with the stiffness, but the instability has become worse. And with time, the femur and the tibia will fuse because this is bone, and eventually you're going to have a worsened deformity. But that's what they used to do because that's what they could manage. They didn't have any implants. Then came about, now it's not moving. Okay, you can change the slide for me? Okay, we have a problem. Sorry, they're working on it. Sorry, okay, it's working now. It's working, okay, that's fine. Now, that's what they used to do, excision. Then came, this was done for about 70 years. Then came the era of interpositional arthroplasty. So they don't have implants, again, it's changing slides, but what they would do, okay, maybe you remove it from even slideshow. No, it's not moving at all. Okay, seems to be working now. So they used to excise the joint and leave it like that. And that was practiced for about 50 years. Then came interposition. And maybe you should just remove the this slideshow and leave it as. Just go manual, there's a problem. This one. Okay, so you change slides for me and I. Okay, it's okay, we can work with that also. We can work with that. Sorry, so that was excisional arthroplasty, removal of the joint, distal femur, proximal tibia in your left like that. With time, the deformity gets worse. Then came the era of interpositional arthroplasty. This was made of elephant tusks, and they would cut it and polish it, and they would place it there and hold it with a long screw. So what is it trying to do? It promotes the stability. The collateral ligaments are now taut. This one is preventing translation anteriorly of the femur, so it's doing the work of the PCL, posterior cruciate ligament, but the ACL is not there. So again, there's still a bit of a problem, and there was a high failure rate of this. But this is what was practiced for almost 70 years before we got the first joint that was developed just in the 60s. So this was the first joint that was developed. You have to remove the whole joint basically, distal femur, proximal tibia. You push this into the femoral canal, tibial canal, and this bulky joint was what they had. Problem with this, of course, is one, a lot of bone loss. You're removing the whole joint. Problem number 2 is high failure rate, and problem number 3 is stiffness, because this is a fixed joint. From physics, don't have to be an orthopedic surgeon. As you know from anatomy, the knee has to roll back for you to get flexion, right? So this was becoming a stiff knee. Then came the condylar design, 1968, where you don't have to remove too much bone, but this was put in each condyle, and this was put into each plateau, and the ACL and the PCL would be preserved to maintain stability. Problem with this is that it kept failing, because this is all that was holding. Problem number 2 is ACL, PCL is preserved, so deformity correction becomes difficult. But this is what they could do at that time. Then finally came 1978, total condylar femur, and this is what is still being used to date, except for being improved over the years for the last, since the 80s to date, it's just more and more improved designs. But there's still a problem. 20% of patients, despite a meticulous job, will still remain unhappy. They just tell you it just doesn't feel right. All studies have been done, 20%, not as good as hip replacement. So now how do we again start improving on this? Came issues of what if it's the surgical technique and not the implant? So now came navigation systems in the 2000s. Basically you do bone mapping and you have this computer that is guiding the process of surgery. As you do the corrections, as you do tensioning, as you do the bone cuts, it's ensuring that you have alignment. But still this was not enough. And this is the perfect example of how not to do a knee replacement. This is a patient who came to me. Joint replacement was done elsewhere. I put this here just to demonstrate the importance of accuracy of joints. Now, this is one of my patients, and just to demonstrate, because we're not orthopedic surgeons, you need a mechanical axis that is aligned and almost a perpendicular joint line. Normally, you want about 3 to 5 degrees valgus. That's how basically to do a joint replacement, and this is how not to do it. Do it joint line and look at the mechanical axis. Joint line and mechanical axis. Now this patient came to me because of revision. Now just to demonstrate, notice there was a fracture here. There was a fracture here. Patella has been fixed. There was a fracture here. So it shows you that if the joint is poorly done, then the outcome becomes poor and this patient keeps falling down. So they kept getting fractures and falling down. Eventually by the time they came, they were wheelchair bound. And of course, the discussion of whether revision is viable or not came about. Now, then came robotics. Now, just a brief history on robotics. What is robotics? The word robot was first used in 1921, sorry, in a play. So this gentleman here wrote a play in Czech Republic. And by the way, that was about 36 years before the first robot was developed. The first one was 1954. So in 1921, there was a play about robotics. So what robotics came from is a terminology to describe robota, which was forced labor. So this guy came up with a play where they were making artificial human beings and forcing them into labor, and they were doing all the hard jobs. But then, unfortunately, the robots got annoyed. So there was a revolution of robots, and they beat up all the people and eventually killed all the human beings, and there was an extinction of the human race. That was that play, 1921. So that's how now robotics started, where the concept of robots came and they started being developed in all basically industries, production, manufacturing, because they were seen to be precisional. The word precision has been used by several of the speakers before. It just shows you the need for accuracy. And what it was offering is, what has happened now? It's okay, we were doing okay without full screen, at least we were surviving. It's okay, so it's fine if it's not working, just so that we don't keep stopping. Okay, sorry. So robotics started picking up. And the first robotic surgery was documented in 1988. It was a brain biopsy that was done with this system. This was a Puma system. It was actually used commercially in manufacturing, but modified for care, for healthcare. And then came a TURP that was done in 1991. And I'm sure we all know about the Da Vinci system that was developed in the year 2000. And since then has been through several generations of improvements. And that's how the Da Vinci system looks, that allows for long distance surgeries. Robotic joint replacements also started in developing. So it started from passive, the navigation system we talked about, all the way to semi-active, where it is only participating by placing the cutting jigs, all the way to now more active systems that are actually participating in the surgeries. But I want to emphasize that it's robotic-assisted surgery, not robotic surgery, because I mentioned this when I mentioned to a patient that we're soon starting robotic surgery. She'd say to me, I don't want a machine operating on me. It's a tool. It assists as the surgery is ongoing. This was during my training. And you have the robot assisting to ensure that you have precisional bone cuts. Once the bone cuts are accurate and they're precise, then the implant sits in perfect place, and you end up having now a better outcome. And apart from that, it also protects the soft tissues around, because as you would imagine, as you're doing bone cuts, the soft tissues injured will heal by fibrosis, then the outcome becomes stiff and a lot of pain. Now, I put this video just to demonstrate. If you can just make it play now that we're not on sound play. Demonstrate. That's how typically we do bone cuts. So I'm using an oscillating saw on a free hand doing the bone cut. Now here I was doing the femur cut, and I was feeling whether it feels okay, is it smooth, is it okay? And that's how we do it. Nothing stopping me from going there. Remember, there's a bad boy there called the popliteal artery. So issues of safety, that's freehand. Now that's the freehand bone cutters, how we do it conventionally. Now even holding the saw like this, if I tilt my hand just by 1 degree, what will be the effect of that downstream? Remembering from physics, the moment arm. Here you have changed 1 degree, what will be the effect down as you walk, right? If I tilt my hand medial valgus, even by 1 degree, what will be the effect? Now compare that one with this. It's unlikely to tilt once you've put the program. These are bone cuts, huh? That's the femur condyles. Now that's what robotics is doing for you, precision. So that then you avoid such, and you have something even better than this one. It's more precise. Now what does robotics offer? Accurate implant positioning, so you're able to see how the implant will look even before you go onto the operating table, and then be able to reproduce exactly that on the operating table. You can actually predict how it will look, and you can see it from the front, coronal views, anteriorly, inferiorly, tibial placement, you can see it from above, and you can see, all right, looks okay, is there any overhang? And it actually even has formulas where if there is any deviation, it raises an alarm with artificial intelligence, and we're living in the era of AI. Then now, safety. Once you've done the plan, the robot system basically decides this is where I'm going to do the cuts, as we saw in the video. And it also plots an area where I don't want to do the cuts. And the moment the milling system on the saw crosses the green part to the red part, it will switch off within 0.1 of a second. Now that tells you something about safety. I don't think I can manage to switch off within 0.1 sec. As you're doing robotic surgery or robotic assisted surgery, you're able to take placements and measurements and angles and very many factors that you can actually measure intra-op, whereas conventionally what we'll do is do the surgery, then we go and look at post-op x-rays, and we look at them like, oh, I could have done better. But now it's too late. You're not going to go back and open him up again, right? So it's probably too late. So this gives you intraoperatively real-time feedback. So the benefits of robotics is a precisional cut. You get very precise cuts, sub-millimeter, sub-degree accuracy. Accurate implant placements. The moment you have perfect cuts, the implant sits in perfectly, and therefore now that has an effect, of course, on the outcome. The balancing, of course, now just to demonstrate on flexion and extension, you want an equally balanced joint, or else it's going to be unstable in one of the positions as you walk. Proper ligament tensioning for stability again, and preservation of periarticular soft tissues. All the tissues around, it doesn't touch. So therefore now there's not going to be issues of pain postoperatively, there's not going to be issues of stiffness, etc. Now, of course, what is the evidence for this? I picked up a few papers. There are lots of papers on robotic assisted surgery. This is one paper by this team over here, and they basically took 40 patients, and they were comparing conventional surgery versus robotic surgery on all, and doing the surgeries, and then now they were measuring outcomes. So they found that there's a less post-operative pain by a p-value of 0.001. I saw from the program there was statistics and research methodologies all done. So this is highly significant. Decreased HB by 0.001, so less blood loss. Less time from straight leg raising test, basically a measure of outcome by p-value of 0.001 for robotic versus conventional. Less inpatient physiotherapy sessions by 0.001, again, highly significant. And less hospital stay, again, with robotics. This is another paper that was comparing robotic versus conventional and looking at the soft tissue compromise, and they found that there's a reduced bone and periarticular soft tissue injury in robotic assisted for obvious reasons, as I've shown you. 3 months post-operative outcomes. Robotic assisted surgery by this team have equal or greater improvement in 9 out of 10 of knee scoring systems. This is a measurement of the outcome. There's a whole scoring system that is done, and they found that out of 10 of them, 9 were improved in robotic assisted, then conventional. 1 year post-op satisfaction. This is a team that also did a study, and they compared 53 patients being operated conventionally versus 53 robotic, and they found that there was a significantly lower WOMAC score. There's a scoring system for post-operative outcome of knee replacement, indicating that it is improvement in robotic-assisted surgery by p-value of 0.005. Then 1 year satisfaction. Again, another study by this team over here. And what was their finding? 94% patients either satisfied or very satisfied by robotic-assisted compared to 82. Remember I mentioned that there's a problem with knee replacement. About 20% of patients are not very happy. So when it's done robotically, that 20 comes down to about 6% that are not very happy. That is significant. Then another paper by this team that was published on the year 2020, comparing the two, and they concluded that patients under robotic had excellent outcomes in multiple PROM scores. PROM is patient-reported outcome metrics score. Another paper, again, comparing the two, and again, they found much significant findings, improved surgical outcome and accuracy in robotic compared to conventional knee replacement. They have longer intraoperative time in robotic, as you saw the robot cut slowly. However, shorter hospital stay, lower rate of readmission, and long-term cost of less revision. For anyone who's known anyone who's gone through revision, no replacement surgery, you will know that revision joint replacement surgery costs not less than 1.5 million shillings. Now, if you're going to reduce the chances of that, then look at the savings compared to conventional. Patient outcome, therefore, faster is that here we will be having the first surgical robot in Eastern Central Africa being launched, and we will be starting to do robotic knee replacement surgeries in Metropolitan Hospital. Thank you very much.
Great stuff, great stuff. Thank you, Doctor. So thank you, and thank you, team, for sitting and listening this morning. We are done with our morning program, but we have a short window for Q&A. So I think we'll take a few questions. Should we have the speakers in front? Yeah, please. Just remember. So let me just request chief guest. Tell the student is a chief guest. Yeah. So if stay in the middle. So if you have any question, please raise your hand. Just say where you're from and then shoot.
Thank you to. Hello. It's not working. Maybe I speak loudly. Can you hear me now? You can hear me, yeah? Okay. So my name is Dr. Mariam. I am from Coast General Teaching and Referral Hospital. So I have a few questions for some of the speakers. First of all, those were amazing presentations. I was really engaged with each and every one of them. So my first question is to Dr. Hibo. About the lung cancer patients, it was interesting that most of the patients did not have active smoking as a risk factor. Do you think that maybe if they were not active smokers, were they maybe secondhand smokers, and that was their risk factor, or is it environmental? What are we thinking about? Because like for breast cancer now, you all know I'm involved more with breast cancer, and most of my patients don't have a family history. And we start wondering, is it the environment? Is it the diet? What is it? So that's my question to you. And to Abdul Naim, first of all, I'm really impressed. Well done. I think he deserves like many rounds of applause. Because so many of us struggle a lot with research. I know I do. So well done, well done. And if I'd be very happy if you're interested to do anything with breast cancer, so please let's speak. About the FMT, is it done anywhere in Africa? Is it done in Kenya? That's my question to you. And to Dr. Faraj, it's exciting that the robotic surgery will start in East and Central Africa in that hospital. My question is, now as a human being, you said you may not be able to stop at 0.1 second. Even though the robot is able to do that, is there a chance that maybe the robot may hang or it may be hacked? I don't know. And then it starts doing its own things. That's it for me. Thanks.
Thank you, Doc, for the question. I think to answer, majority of our patients now, we're having more females who are non-smoker with adenocarcinoma specifically as a histological subtype. I would not say passive smoking. Majority were from non-smoking family. Were not exposed to, I would say,
Okay. So majority of the patients were not from a family where they are exposed to passive smoking, but of note is use of bio fuel like kuni and what do you call it in makaa, the charcoal could be, but no smoking, and mostly with the histological subtype adenocarcinoma, which is common in non-smoker. So yeah, maybe environment.
Maybe to add on to that, are they from the rural areas? Maybe, you know, the rural setup where they have a room of mabati and they are using firewood and the room is really smoky. Could be.
Not many. Okay, they are from different areas because it's majority of the patients that are coming to Kenyatta are from different locations. But for those ones that are not coming from families that are smoking, they're not all of them. Like that's one of the things that we find, they're using charcoal and all those things, but not necessarily. Maybe Abid can help with that question more.
Answer your question.
Okay, shukran for the question. FMT is like an emerging procedure, but it's not yet widely used. It's mostly in the Western Europe and in America. But in Africa, specifically, it has been used in South Africa, but not in Eastern or Northern Africa. Yeah, thank you.
Just to add on it, basically what we have in Kenya first, Clostridium difficile is quite rare. Surprisingly, with the widespread use of antibiotics, we still have very low rates of Clostridium difficile, both in hospital patients and also in the community. So our antibiotics still work. Of course, there's still recurrence. For those who have C. diff, the recurrence rates are still high. And the program for fecal microbiota transplantation, it's difficult in these parts of the world. First, we have to, especially with the infectious diseases, to processing having the setup to process the stool, collecting the stool. You know, you have these donors out there, they have to get the stool and send it to the lab for processing. So you need multiple donors to get a good microbiota. So I think we're still far back. So probably even the drugs used for C. diff, we don't have all of them. So we still rely on oral vancomycin and metronidazole. The other one, fidaxomicin, we don't have in the country.
Thank you for the question, Dr. I think my question was whether there's a chance of hacking of the systems. Now, maybe. One thing I should mention is robotics started some time ago. It's only that we happen to have been left behind in the years. They've been in commercial use and routinely used for the last almost 20 years. And before any of these robotic systems are implemented, they have gone through multiple levels of trials, quality assurances, etc. The joint replacement robotic system is actually not the Da Vinci system where it's web-based. This one, how it works is patient CT scans are uploaded onto the system, then there is a planning that you do, basically simulation of the surgery pre-operatively, and then it codes it into a program which you then carry it in a flash disk and load it into the robot, and then now it's then executes. And during the surgery remains, as I mentioned, in control. Surgeon will expose, do the cuts, skin, arthrotomy, etc., get to the joint, then take a step back and the robot does the bone cuts only. And then now implantation is still done by the surgeon. So it's not a web-based system. That's one. I think in this part of the world, our biggest problem that we should be fearing more than hacking is actually power blackouts. Maybe the question would be, what if the electricity switches off intraoperatively? What has happened is there has been improvements in the robots. What we're actually implementing has a UPS system that can do 2 surgeries on power backup system. Yeah, so I don't think there's a chance of hacking because it's not a web-based system. Yeah, hope that answers your question. Dr. Shahbal is asking what is the cost. The cost of the robot is on average about 100 M upwards. So the initial investment is quite heavy. But then there comes the question of what is the cost effectiveness. If you're bringing down hospital stay, you're bringing down the chances of recovery, revision surgeries, you're bringing down, you're enhancing the outcome of surgery, then it is probably a worthwhile investment. And there was actually a study that did financial analysis of the outcome, cost effectiveness, and all those other parameters of financial analysis, and they actually found it to be very cost effective. Yeah.
This panelist is the one with most questions. If you compare open knee replacement to the robotic one, what are the costs to the patient? Is there a difference?
So just to clarify, they're both open surgeries. The difference is because it's not endoscopic versus open, they're both open surgeries. The difference is that the robot is coming in to do the precisional work for you. And there is a major implication. I recognized that the audience is mixed, therefore I did not put in papers that are looking at now biomechanics and the physics behind joints. But then they're both open. The difference is now this one is giving you the precision, the safety, etc. What is the cost on the patient? There are some consumables that are utilized on the robot, including drapes, including the high-speed bar that you saw on the video. But then to bring down the cost, what is happening is some of those consumables can be re-sterilized using ETO, and therefore now you bring down the cost to the patient. So the cost difference becomes quite small versus conventional versus robotics. Probably would say an additional 20%, 25% of the cost of conventional.
Okay, great. I think we're also running out of time. Before the panel leaves, I would want to give final ask to Abdullahi. Now that you're in a panel with your seniors and some of your seniors here, what is your ask? Not to you personally, but how do you think we can do better? You know, sometimes from our angle, the way we see it, we might have solutions that maybe don't make sense to you. So what do you think we can do better to support students like you who want to do more research and such like? What would you say to us as a final word?
Okay. I don't know how to answer that like clearly, but you can become you can be open to students to allow them collaborate with them, so that you hear what's their idea or what's their and you can also collaborate in your research so that they become aware of the current emerging technologies and emerging research. That's okay.
Thank you so much, and sorry for putting on the spot. Please, we appreciate the team. And then I'll hand it over to the
Thank you so much. I'm just surprised with Dr. Mariam. She was very selective, the people to ask. Some people she was avoiding to ask the question. I wonder why she was that selective. Just to put it in perspective, actually we have been working with Abdul Naim for the past 2 years. We are trying to help him. There are some challenges with his work. There's a good work he's doing. And we're coming to you, Dr. Mariam, because you requested. There's something he's doing in breast cancer. He didn't want to stay on the stage, but I know he's doing it. So we're coming to you. Thank you. My questions is it's not a question rather, my challenge to Dr. Faraj and Dr. Shabal. What you have showed us here, this is amazing work, especially the groundbreaking part, what you guys are doing in terms of pediatric and everything. I wonder if you are considering putting this in publication, because sometimes we see very funny articles in the journals, yet our work is more impactful. I'm really challenging you guys to take this one forward, so at least we can have our local data, like how you started. I really like it, like how you broke it down, the number of pediatric anesthesists, pediatric surgeons and everything, including what you mentioned, like she went for this conference, you never found anything. This is very important because we are going to attract more investors, because now all of them, they are moving towards Africa now, because they have trying to realize, like Africa, we have more potential in terms of numbers. In Europe and Asia, they're already saturated. We are growing up for, they have opportunities for them to market their products. This is bringing collaboration indirectly. Just to answer Dr. Mariam about the fecal matter, we on oncology were ahead in terms of fecal matter. You remember the story of Nabino? When they went to poo in the boat, then somebody fell, then it became treatment. So now we oncology are already going to use that one for treatment in colorectal cancer. So it's already coming, and it is now moving towards breast cancer. So be on the watch. That pool of yours, we're going to recycle it and give it back to you as part of your treatment. Thank you.
Thank you very much. Challenge taken. Challenge taken, Dr. We will consider that. In response to the young doctor, I think as Dr. Shahabal mentioned, he went through a very difficult training. I remember that was one of the things he said, and the consultants that trained us were of different caliber than the current consultants. So feel free to approach any of the consultants. I'm sure everybody would be very willing and happy to to mentor you. Shred there has worked with me for over a year. He's joined me in spine surgeries, arthroplasties, arthroscopies, you name it. And he's yet to complete his medical school. And I don't think I was harsh to him at any given time, was I? He says no. Yeah, so feel free to approach them for the younger ones. People are willing to mentor and teach. Thank you.
Thank you. Any last words from our panelists? I think for the rest of us, this is a rallying call. There are students out there, there's a lot of potential out there. Let's be proactive sometimes in reaching out to them. Sometimes it's easier. We always ask, they don't come, but we are not very approachable sometimes. So let's make it intentional. Reach out to our students, registrars, and all that, so that we mentor them. I think somebody wants to give feedback to Dr. Faraj. Just meet them. Your students.
First of all, before I get to thank Dr. Faraj, to the students who are in the room, kindly don't be like, I can't approach this guy, I can't talk to him. I mean, he's way superior. When I did that with Dr. Faraj, it was like 2 years ago right now. And Alhamdulillah, he's been, he's twice the age I am. And but one thing that I can say, he's been like a father figure to me, he's been a friend, he's been a brother to me. So I don't even have like that title to give him, like he's like a father or he's like a friend. I don't know where he is. He's someone that I can just talk to him over anything. I can just go to him and be like, this is what I have in mind and what do you think and all that. So to the students, please, if you see that there's someone in the room or that you've gotten to know and you feel like this person can really help you, please reach out. I think that is what Dr. Faraj has instilled in me, and I've really thought of it, and Alhamdulillah, now I've chosen my career path just because of him. So mine is to thank you. Only Allah can reward you. Inshallah. Shukran.
Dr. Faraj was my junior in high school, Sheikh Alifa. So now I feel offended. I feel very old.
Can I just give a short story to tell you the kind of consultants we had? So it was a weekend, Saturday. So no, it was a Friday evening. I got a patient with intussusception. We had a junior consultant who used to do calls from Monday to Friday. Then on the weekends, he took a rest. The senior consultants are the ones on call. So on Friday evening, I get a patient with intussusception who truly was severely dehydrated. So the junior consultant tells me, listen, I'm tired. What you do, you say you are resuscitating this patient overnight. Then in the morning, when he's more stable, is when you go to theater, which was the right thing to do. So don't drop the list, drop it at 6 a.m. in the morning. I told him, okay. But then I had to warn that senior consultant, right, that I'll call you early in the morning, we need to go in. Then I made a mistake. That was a mistake. When I called him, he was like, no, it is mechanical obstruction. You have to sort it out. If you resuscitate, will it sort itself out? So, because I knew the child needed resuscitation, I didn't drop the list, I dropped it in the morning. So I still called him in the morning. He came, but he blasted me from morning to when we finished the theater. Then I was being called to casualty. He was asking me, is there someone covering casualty? I told him, no, it's a weekend, I'm the one covering casualty. So we finish, I go. Then he was like, no. So I was being blasted for not having someone else going to casualty. At the end, when I went to casualty, luckily for me, it was a patient with an erectile malformation. It was a boy, so it was again another mechanical obstruction. It's now evening. When I'm calling him, he's telling me, resuscitate the boy. I told him, no, you cannot resuscitate. This is mechanical obstruction. You blasted me from morning to now. Let's go back in now. So I actually dropped the list. And from then on, he became respectful.
Great, great, great. Thank you so much.
Sorry, I was once told that I will make your life miserable because I didn't know the consultant was on leave. That's how it was.
So I think all of us have serious traumatic experiences of how we've gone through training. It will be unforgivable if we keep that tradition ongoing. Whatever happened to us, it was bad then, and we know how much harm it can do. It becomes our responsibility to break that cycle. So for that, thank you so much. Please help me appreciate our panelists. Okay.
Now, let me just twist the coin on the other side. Alhamdulillah, with the current consultants, we can access the leniency and the or junior colleagues who can take over, inshallah, in the years to come. So we should not take our leniency and humbleness for granted. So, and we are getting these challenges, and Dr. Hakimi, I can hear her saying true, and she's a witness to this. And maybe Swala, you witnessed in our interns, and all of us, right? And it's shameful to see, sorry to say that some non-Muslims are more eager in the same group than our own Muslims, female probably, and male interns or medical officers, which is not right. So inshallah, take it as a positive thing. Let's see the eager. In recent time that I think Nafisa and the rest can attest, I always tell them, if you join me for the round, I'll teach you. If you think you're too bright, you're busy, okay, I'll do my round, I'll go out. Period. Because I have other things to do. Because you cannot pull a donkey and force it to drink water. But you can give the water to him or her. And if you want to drink, well and good. If you don't want, it's okay. So I don't know in the universities, maybe Dr. Faraj being in the teaching university, are you experiencing the same thing? I think it's similar. So let's try to change this culture. Let's be proactive. Let's show and shine. And it's unfortunate, the other world, you see, when you see a hijabi and they're doing some things like fraud, cheating in exams, they really magnify it. But the rest of the people are still doing it, but you never see it anyway. So it's like we are on spotlight. The reason being, outside here we are shining, so they're trying to bring your morale down. So take it up. Be disciplined, be hardworking, trust night, read, group discussion. You are in a university for an aim, internship is still training, and once you qualify, we are being available to mentor you, whatever level you want.
So thank you. I think, thank you so much for that. We are a bit late. We will be having the Chair of Council of Governors coming up. After the break, we are meeting back up at Arabuko. We will not be coming here. We will be having plenary. So we will be breaking now. Please visit our supporters on the other side. I know they appreciate it a lot. Have your tea, have your coffee. Then in the next 10 minutes, if possible, let's meet up so that we don't delay the program. Thank you so much to our panelists.
الذي ينفعنا رب فقهنا وفقه أهلنا وقرابات لنا في ديننا ربنا انفعنا بما علمتنا رب علمنا الذي ينفعنا رب فقهنا وفقه أهلنا وقرابات لنا في ديننا